And then just as before we bring the meeting to a close, we've got the short oral presentations. This is a new part of the meeting for us, so I'm very excited about this bit. So we've got 6 short presentations, and they're in alphabetical order. I'm going to let people introduce themselves as they come up. Are our 3 judges, do they want to come and... Do you want to sit at the front here and do your judgy thing? Thank you. Cheers. And if we could just keep to time just to make sure people can get away. So we've got Miss Diana Marcus first. Thanks.
That's so bright, okay. Can I start? Yeah. Okay. So hi, my name's Diana. So today I'm going to be speaking to you about the outcomes of women who presented to an urgent suspected gynae cancer pathway with bleeding with or without HRT. So you'll all be familiar with the BMS update. So on the right is a screenshot basically of their pathway or their guideline update. We had hoped actually when it came into practice we would actually see a reduction in the women who presented to our clinic with postmenopausal bleeding. This remains to be seen. In fact, if anything, we're still getting increasing volumes of cases. So really what we wanted to do is to compare histological outcomes for women with and without HRT to assess their cancer risk in these different groups, to see if we're following the national guidance, and to see if there's anything we can do in our service to improve our own pathway and to make things better. So in terms of method, this was quite a large audit. So it was a 1-year retrospective audit of all consecutive patients that came to our suspected gynae cancer clinics from January 2023 till December 2023. So ours is 2 sites. It's a trust of Chelsea Westminster and West Middlesex Hospital. And we are, for those who don't know, we're the second busiest kind of gynae referral centre in London. So in our population, we had seen just under 5,000 cases on the urgent suspected gynae cancer pathway. And of these, over half of these basically came in with bleeding with or without HRT. In the audit, we were looking at scan findings, hysteroscopy findings, histological outcomes, and also demographics too. Overall age range, median was 57, which is probably not surprising, is in keeping with what you see in practice. Range was between 27 and 97. The younger women were referred in had a history of premature ovarian insufficiency and more often on the HRT. This is quite a busy slide, but it's also quite interesting, I think. The overall denominator here is 2,580 women, all came in with postmenopausal bleeding. On the left side, you can see I've split it into women on combined HRT, sequential HRT, and no HRT, or no systemic HRT. So the sequential HRT is actually a really small minority of the volume that we see, so only 3% of our case volume. And the remaining cases were split roughly between combined HRT and no HRT. When one woman came in, we have a one-stop service, so all of them were offered ultrasound scan at the point of clinic, and about a third of the women, irrespective of whether they were on HRT or not, had normal scan findings. And what we mean by normal was a thin endometrium of less than 4 millimeters, and the lining was seen clearly throughout. A large volume of women ended up having tissue sampling it, be it Papels or hysteroscopies. And of these different groups, you can see on the combined HRT, the rate of cancer was exceedingly low, so 0.5%. So we saw over 1,000 women and only 6 cases were picked up. Versus the women on no HRT, the risk was 10 times higher, so 5%, with sequential lying roughly in the middle, which does give an overall cancer risk of just under 3%. Some other interesting findings, speak for a long time, but 1 minute left. Okay. The Mirena. So we were curious to see whether women who had a Mirena core at point of referral, whether we saw any case of cancer, and the short answer is no. So there were no cases of endometrial cancer in women who had PMB with a Mirena core in situ. But it had to be an in-date Mirena core. So we had one case where the Mirena core wasn't changed for 30 years and was still there. We picked up an ovarian cancer with a granulosa cell tumour, and one lady with atypical hyperplasia where they thought there was a coil, but nothing was seen at hysteroscopy. And then, I've got probably 30 seconds, we were also curious to see outcomes difference whether women had Papel versus hysteroscopy. So we know hysteroscopy is the gold standard, but we don't really have capacity to do that for every patient. So we had over 1,000 women underwent tissue sampling with about adequate tissue samples for about 80%. Of these, 200 women also had concurrent hysteroscopy. So they had Pipelle, and within 2-3 weeks, they also had a hysteroscopy, be it GA or outpatient. Interestingly, about 5% of the time, the histology was upgraded, so it was worse. So either it was normal, and then it became simple hyperplasia, so no atypia or cancer, or atypical hyperplasia. And about 5% of the time, the histology was actually downgraded. So they thought it was either atypical hyperplasia or hyperplasia no atypia, and it was actually normal. So I thought that was quite interesting too. So in conclusion, postmenopausal bleeding still represents a very large volume of the work we do. The women with no HRT have by far the highest risk profile. We rarely see endometrial cancer with a marinocolon in situ, and the diagnosis will change about 5% of the time if you were doing a hysteroscopy and a Pipelle at the same time.
That's great. Thanks very much. Dr. Joanne Moffat, please.
No questions.
Hi, my name's Jo Moffat. I'm based at Somerset Foundation Trust as a Gynae Oncology Clinical Fellow. Thank you for inviting me to speak about our study, which is on the impact of location of care for patients diagnosed with or investigated for a gynecological cancer. So, gynae oncology services have largely evolved from existing services rather than being designed specifically around patient need, and they're often co-located alongside other women and children's services. This negatively impacts our patient group for multiple reasons. A pilot study revealed that only half of patients referred with a suspected gynecological cancer are seen separately from obstetric patients, but this number falls to around a third in patients who are seen in cancer units. So, Graceful One is a UK-wide web-based survey promoted by hospital trusts and gynae cancer charities, collecting quantitative and qualitative data on experiences and preferences for place of care for people being investigated for or diagnosed with a gynecological cancer. Graceful 2, which is running alongside it, is I'm conducting semi-structured interviews with participants who volunteered to share their experiences in order to gain deeper understanding of their perspective. These two phases are currently ongoing, and I'll briefly discuss the preliminary results from Graceful 1. So to date, 271 participants have completed the online survey. The respondents are from well-distributed groups with a range of ages, parities, and diagnoses represented. So this chart demonstrates responses to questions about place of care using a Likert scale. So the interesting points that we have found from this is that 55% disagreed or strongly disagreed they were happy to be seen alongside maternity patients, and 69% agreed or strongly agreed they prefer their care to be separate from maternity. Unsurprisingly, 81% would be happy to be seen in a separate gynae oncology service. One point is that this opinion was not unique to young nulliparous patients and was seen across the range of different patient types. So this chart compares the location of the participant was seen in, which are the blue columns, with their preferred location, which is the orange columns. So 75% preferred their care to be in a standalone department. This is some preliminary qualitative analysis from free text comments from the study, which showed that people value female-only spaces and access to specialist services, but they also want their services to be accessible and to limit travel time. Formal qualitative analysis will follow for the free text responses and the semi-structured interviews when the survey closes. So our aim is to generate data to influence change in how and where we deliver gynae oncology services. Following on from Graceful 1 and 2, we will develop a discrete choice experiment which will ask people to weigh up various attributes relating to the location of care, such as travel time and access to specialist services, to understand what value they place on these preferences. We're also seeking views from staff delivering care to these patients in a variety of settings, and non-clinicians who are involved in service design and planning in order to understand barriers to changing services and where they're located. So thank you to my supervisors and our funders. We would greatly appreciate any expressions of interest for ongoing work, so please do get in touch with the QR code or via email if you'd like to be involved in the next stages. Thanks.
Thank you. Dr. Tobeki Noku.
Hello everyone, my name is Lobechi. I'm an Upsangana SPR at Nottingham University Hospital City Campus. I collaborated with my friends from Wrexham Maylor to do this case report. So beyond infection, when sepsis signals sarcoma, case report.
Sorry, could you stand a bit closer to the microphone?
Okay, so beyond infection, when sepsis signals sarcoma, this is a case report. Patient managed at Wrexham Maylor Hospital at Wales. Uterine sarcomas are rare and aggressive gynecological malignancies. They're even rarer when we have undifferentiated uterine sarcomas. Diagnosis is rarely made prior to pathological examination of myomectomy or hysterectomy specimen. So it's really difficult to make a clinical diagnosis of undifferentiated uterine sarcoma. Differentiating between uterine leiomyoma and sarcomas can be challenging as there's a bloodline in their clinical and imaging features. So this was a case of a 66-year-old woman who came in with features of sepsis. And she eventually had septic shock, unfortunately, and was transferred to the ICU. She had a CT abdomen and pelvis, which suggested a necrotic uterine mass with posterior uterine perforation. So following stabilization in the ITU, she eventually had, a decision was made to have a laparotomy. And there was an intra-op finding of inoperable bulky uterus with posterior uterine perforation and some collection. She had a peritoneal wash, and biopsies were taken. And post-operatively, MRI was done, which supported the diagnosis of high-grade uterine malignancy. Histology confirmed undifferentiated grade 3 uterine sarcoma. She has since been referred to Regional Sarcoma Service following MDT. The picture showing very necrotic tissue up there. So uterine sarcomas are rare and aggressive tumors with poor prognosis, typically diagnosed at about 60 years of age. More than 2/3 of patients present an advanced disease, and it's quite difficult to make a diagnosis preoperatively, including even imaging. And that's why currently the development of AI-generated algorithms try and help the radiologist to make diagnosis. Presentation is often a triad of abnormal vaginal bleeding, rapidly enlarging pelvic mass, and pelvic pain. However, this patient presented in sepsis, and it's quite instructive that patients who have advanced cancer can present in sepsis, especially even with sarcoma, which is very rare. Atypical fibroid findings on pelvic ultrasound should be referred for MRI, which is very important. Sadly, this patient had MRI after an attempt to do a surgery. MDT is quite essential. Total abdominal hysterectomy and BSO is the recommended treatment for early-stage disease, while for advanced diseases, aggressive surgical cytoreduction for advanced disease, including chemotherapy and radiotherapy. Prognosis is generally poor. For early disease, 5 years survival is about 50%. There's quite a varied degree of reports in the literature, but for advanced diseases, the prognosis is for 5 years survival is as low as 20%. In conclusion, undifferentiated uterine sarcoma is rare, aggressive, and with poor prognosis. Diagnosis is quite challenging clinically and radiologically. It can present acutely with sepsis, like in this patient, and can sometimes mimic tuborovarian abscess / pelvic abscess. MDT involvement is vital early for oncological planning, and surgery is the mainstay of treatment. It's my reference. Thank you. Thank you so much.
Thank you very much. Mr. James Phillips.
Good afternoon, I'm James Phillips, I'm the unit lead in Nottingham, and your second talk on HRT, so you can tell what topics are on people's minds. So background, so NICE suggests that a woman or anybody with a 3% risk of cancer warrants a suspected cancer referral. Literature tends to quote a risk of cancer with postmenopausal bleeding in the region of 5 to 10%. HRT rates we know are increasing. Urgent suspected cancer referrals are increasing. We've seen about a 25% increase over the last 4 to 5 years in Nottingham. Our cancer waiting time performance, as in other units, is poor. Our FDS is around 50%. Our first appointment for patients with PMB is around 22 to 36 days. And the BMS guidance was hopefully going to help with this, but again, we're seeing fairly similar numbers before and after. So the question really for us is whether these patients warrant being seen on a suspected cancer pathway. Some colleagues of mine carried out an audit before the BMS guidance came in. 340 patients over about 5 months, showing a 1.5% risk of cancer and of atypical endometrial hyperplasia, and then no predictably reliable risk factors. It's a variety of endometrial thicknesses, a variety of BMIs, and a variety of ages. So then after the BMS guidance, we wanted to see whether this made a difference to the patients that we were seeing. So 6 months this year, looking at all the women referred with unscheduled bleeding on HRT, looking at all of their histology reports. We also looked at all of the new endometrial cancer and new atypical hyperplasia diagnoses over that time to make sure we hadn't missed any women that were on HRT. So we had 370 patients. There was 1 case of atypical hyperplasia. There were 3 cases of cancer, so about 1% risk overall. And again, a variety of different features and no clear predictive factors that would help us to identify a subset of patients that perhaps do warrant a suspected cancer pathway. So in conclusion, the risk of cancer and atypical hyperplasia for those women with unscheduled bleeding on HRT is low and doesn't warrant a suspected cancer referral. Timely investigation is still required to exclude cancer, to reassure patients and to control their symptoms. There are some limitations. A small number of cancer cases here makes it more difficult to identify that those that do have particular risk factors where it may warrant a suspected cancer pathway. There's also relatively low numbers of women from minority ethnic backgrounds, and so we've got a lack of evidence that this approach is safe for that group as well.
Thank you. Dr. Innes Rees.
Hello everyone, my name is Ines and I'm SC5 and I'm currently working at Northampton General Hospital. I'm pleased to present our study on the role of peritoneal fluid cytology in the diagnosis of ovarian cancer. This is a brief outline of my presentation. So why this topic matters? Our current guidelines recommend obtaining a tissue biopsy when it's feasible to have the definitive diagnosis through histology and molecular studies. However, as we know, tissue biopsies are not always feasible due to patient frailty, tumor access, or any other complexities. Peritoneal fluid cytology might give us an early diagnosis and also is a rapid and a cost-efficient diagnostic test. As we also know, in advanced ovarian cancers, neoadjuvant chemotherapy might be the most suitable treatment options. Therefore, having a final diagnosis is crucial to start the treatment and to improve patients' outcome. So we aim to investigate the concordance between peritoneal fluid cytology and histology in patients with advanced ovarian cancer, stage 3 and 4, and to assess a quicker and a cheaper diagnostic test. It was a retrospective study. The period of time was between November 2018 and May 2025. And after applying our inclusion and exclusion criteria, we have a final sample of 38 cases. This table summarizes our results. The mean age of our patients was 68 years old. The majority of them were postmenopausal women, and 92% have the ratio 1 to 5. And we also assessed the final diagnosis of the cancer. I would say these are our key findings. There was a 60% of concordance between peritoneal fluid and histology, and among those, high-grade serous carcinoma accounts for 91%, followed by the low-grade serous carcinoma. 61% of the cases have immunohistochemistry tests done on the peritoneal fluid. We also look at those who there was no concordance between the peritoneal fluid and the histology, and adenocarcinoma makes up the majority of the cases. There is also a notable report of no malignant cells on the cytology fluid, which corresponds 13% of the cases. To conclude, our study supports the existing evidence that peritoneal fluid still has a limited value as a diagnostic test. High-grade serous carcinoma has the highest concordance rate, and further research is still needed, and large-scale studies are needed to validate our preliminary results. My reference, thank you so much. This is my email. We are currently waiting an approval for a research project on this matter. Thank you. You can drop me an email.
And then finally, Miss Selina Chu.
So good afternoon. I'm Selina Chu. I am a clinical research fellow at Imperial College London, and today I'm presenting squamous cell carcinoma of the vulva, a decade of observational data. So as we understand, vulvar cancer affects 3 to 5% of all gynecological cancers and affects approximately 1,400 patients each year in the UK, posing significant clinical challenges for both diagnosis and management. Vulvar cancer can be stratified according to HPV status. HPV-related tends to affect younger patients, progress more slowly, and have a lower risk of malignant transformation, whereas non-HPV vulvar cancer tends to occur in older patients, progress more rapidly, is associated with inflammatory conditions such as lichen sclerosus, lichen planus, and have a higher risk of vulvar cancer development. We conducted a retrospective observational cohort study at a gynecology oncology tertiary cancer centre between 2014 and 2024, and this was for patients that had vulvar squamous cell carcinoma. During this time period, we identified 240 patients with a median age of 71. More than 80% of our patients were diagnosed over the age of 60. With regards to risk factors, lichen sclerosus and immunosuppression were the most prevalent, followed by concomitant cancers. Most patients presented with a lesion or with pruritus. More than 50% of our patients were non-HPV related, a quarter of patients were HPV related, and the remaining were unknown. 60% had evidence of pre-invasive disease, and when we stratified this according to HPV status, a larger proportion affected those that were HPV-related vulvar SCC, and this was statistically significant. 41% of our patients had lichen sclerosus, and in keeping with current literature, this was more evident in those that had non-HPV vulvar SCC. With regards to staging, 60% of our patients had stage 1, stage 2, approximately a third had stage 3, and the remaining had stage 4. Most patients were managed surgically, of which 2/3 had nodal assessment, with a fifth of our patients undergoing adjuvant therapy following the initial treatment.
1 minute.
More than a third of our patients had reoccurrence, and about 3/4 of patients had reoccurrence in the first 5 years, with the remaining occurring more than 5 years. And this was more prevalent in those that had non-HPV vulvar SCC, and also if they had evidence of pre-invasive disease, and this was also found to be statistically significant. So in conclusion, vulvar SCC is a complex disease. We had a greater proportion of non-HPV related vulvar SCC, which differs from current literature. Regardless of the HPV status, we need greater awareness and also a destigmatization of this particular cohort. And I believe that education is central to this, and this is for both healthcare professionals and also patients. Our data also emphasizes the importance of long-term follow-up. Thank you.
If I could just ask people to put their hands together again for all of our short presentations. I thought that they were really good. So just before I wrap the meeting up and allow our judges to collate their bits of information, just a final plug for the BGCS meeting in July. It's going to be a good one down in Bristol. Lots of exciting stuff happening down there, so please come to that. Second plug, if you're not a member of the BGCS and you've come to this meeting and you've never been a member, that means that you, if you contact our administrator, she will give you free membership for a year. And then the last thing I want to say is please fill in your evaluation forms. It really does make a difference when we're planning this meeting for next time, your feedback. I really do try to take it on board. So if I could just ask you to make sure you fill that in as well. And hopefully I've given my judges enough time to come up with some results. So we are going to have a winner and a runner-up, and our winner will be having £100 to be given to them from the BGCS, and our runner-up will be getting £50. And I feel like I should have some kind of drum roll thing going on as our people collaborate. Ooh. It's a nail-biting finish for the posters, the oral presentation, sorry. Yep, okay. Do we? Excellent. Would you like to, Nithya? Do you want to give our prizes? Oh, Nithya, do you want to do? Oh, okay. So in first place, then we have Joanne Moffat. Is she still here? Yay! And then in second place, we have Ines Rees. She's still here? Yeah. So I'm going to draw the meeting to a close. Thank you very much, everybody, for coming, and hopefully I'll see you all again next year.